Imagine this scenario. You are sitting in a silent, sterile hall, the air just thick with tension.
Hmm.
A clock ticks relentlessly down on a screen right in front of you. Your entire career, I mean, years, a decade maybe, of sacrifice, sleepless nights, endless study, it all hangs on the next few hours.
The pressure is
And
immense.
you're not facing just one patient. You're facing a bank of, what, 20 screens? Each one flashing, maybe a high-res echo, a really cryptic ECG, or maybe a devastating clinical history.
And demanding instant decisions.
Exactly. Instant life-saving decisions within, like, 4 minutes. This isn't just a test. It feels more like a crucible designed to filter the expert from the novice.
That's a good way to put it.
It is the DNB DrNB Final Practical Examination, and today we are diving deep into its relentless architecture.
Yeah, let's unpack it.
Welcome to the deep dive. Today we are pulling back the curtain on the detailed scheme, the very blueprint of one of the most rigorous professional assessments in advanced medical training. We're talking about the DNB, the Diplomat of National Board, and the DrNB, the Doctor of National Board, Final Practical Examination.
These are really crucial certifications, especially for specialists in India, but recognized elsewhere too.
Absolutely. Our source material today is the official guide to this high-stakes assessment. We're focusing particularly on the challenging virtual OSCE and then the clinical parts that follow.
Right.
Our mission to really understand the architecture, how this thing is built, and crucially to pull out the essential clinical insights hidden in its sample scenarios. We want to give you, the listener, a shortcut to understanding what high-level clinical competence actually looks like under pressure.
Yeah, what's expected?
Before we jump in, a special thank you to London Heartbeat's Z Academy UK for their educational support of this deep dive.
Great supporters.
Definitely. If you, the listener, are looking to expand your knowledge base, maybe you're a trainee, maybe you're just deeply curious about medicine, we really encourage you to explore their, I think it's over 150 popular courses now.
That's a lot of content.
It really is. They're constantly updating things, too. So don't miss out on free, regular updates. You can subscribe to their social media channels, Facebook, Instagram, YouTube. Get all the latest discussions.
Good advice.
And, for those seeking even deeper engagement, you might consider subscribing to their higher-level YouTube membership. That gives you early access to specialized educational videos and sometimes even personal chats and guidance sessions with experts. Worth checking out.
Definitely.
Okay, let's get into the structure of this assessment.
What's really fascinating here looking at this material is that it offers such a rare, explicit glimpse behind the curtain of how these high-stakes professional assessments are actually designed.
It's not just a timetable, then.
No, not at all. We're analyzing more than just an exam schedule. We're really digging into the philosophy of how competence is measured in high-level medical training.
Yeah.
This whole process, it's designed not just to test what you know, but crucially, how you apply it under some pretty extreme pressure.
Okay.
Structurally, it's very sound. It's built to test synthesis, bringing different pieces together, not just simple recall.
All right, let's start right where the exam guide itself kicks off with the mindset. Because facing an exam, this demanding, 4 distinct parts crammed into a single, pretty brutal day, that requires serious mental strength, right? And a particular way of looking at uncertainty.
Absolutely. Mental fortitude is key.
The guide introduces this with 2 quite powerful quotes. The first one, "What a father told his son, if it is according to your wish, it is good. If not, it is even better."
Interesting perspective.
And the second, simpler, more stoic one, "Whatever happens will always happen for the best."
This framing is, I think, absolutely foundational for any high-level clinician, not just for the exam. It's really a lesson in mental resilience, in accepting clinical uncertainty.
Because you can't control what walks in the door.
Exactly. In the real world, and certainly in this exam, you cannot dictate the clinical cases you're going to face. This philosophy encourages the candidate to, well, embrace the unexpected. If you get that rare disease case, something totally outside your comfort zone,
Yeah.
the mantra suggests that this very unpredictability forces you to rely on core diagnostic principles, on structured thinking. And that ultimately is a deeper measure of competence than just happening to get a case you reviewed last night.
So it forces you back to basics in a way.
In the best way. That process of reasoned deduction, working through the problem systematically, that's what the examiners are truly looking for.
That leads us right into this provocative question posed in the source material, a sort of philosophical turning point for the exam board itself. Was the COVID pandemic a blessing or a curse for assessment?
Well, blessing might be a strong word given the tragedy, but It was undoubtedly a profound catalyst for necessary innovation in how they assess doctors.
How so?
The constraints, physical distancing, travel restrictions, they made the traditional old-style OSCE, where candidates physically rotate between stations, simply impossible.
Right.
This necessity forced the National Board of Examinations in Medical Sciences, NBIMS, to pivot quickly to the virtual OSCE format we see now.
And that's more than just a logistical change.
Oh, much more. It fundamentally changes the focus of the assessment. It shifts the primary pressure away from just hands-on clinical examination technique towards the ability to perform ultra-rapid visual data interpretation.
Like reading scans and ECGs fast?
Exactly. Analysis, intellectual triage, all at high speed. It forces the candidate to become a kind of high-speed data synthesizer.
Okay, let's make this philosophy a bit more tangible. Let's talk about our first case example. We'll call it the resilient resident. Case example 1, the resilient resident. Okay, so picture this. We have a medical resident, let's call her Dr. Sharma. She spent a whole year exhaustively preparing for the 2 big clinical cases in the exam, focused heavily on common stuff, high-yield cardiology, maybe some liver cases, things she saw all the time on the wards.
Self-confident, probably. Heart failure, cirrhosis, got it covered.
Totally. But then, exam day. The 2 cases she gets are way outside this comfort zone. One is a super rare metabolic disorder presenting with vague cardiac symptoms. The other, a complex autoimmune vasculitis hitting multiple systems.
Ouch, that's tough luck. Initial reaction must have been panic.
Absolute panic, frustration, thinking, a year wasted, I got the unlucky draw. It's a common thought process, right?
Very common psychological trap.
But then Dr. Sharma apparently remembered this even better philosophy we just talked about. She realized, okay, trying to magically recall the specifics of that rare metabolic thing, pointless. Yeah. So instead, she fell back entirely on her core diagnostic process. Structured history, asking the fundamental questions about system involvement, systematically documenting physical findings. And this is key, using a structured, methodical approach to list and investigate the differential diagnoses, treating it like an unknown system breakdown.
Focusing on the process, not just the rare answer.
Exactly. And she performed adequately, not because she suddenly knew the obscure diagnosis, but because she demonstrated how a specialist thinks when they're faced with something unknown, which, it turns out, is exactly what the examiners were testing.
That's a perfect illustration. The key lesson here is, in high-stakes situations like this DNB, DrNB practical, resilience and relying on those fundamental structured methods like the methodical framework of the OSCE itself often proves way more valuable than just domain-specific luck or trying to memorize every rare disease under the sun.
Competence is in the methodology.
Precisely. Competence is the methodology.
Speaking of methodology, let's break down the 4 pillars of this high-stakes assessment, because it really is designed as a single-day, comprehensive endurance test. Totals 300 marks, right?
That's right. A marathon definitely structured to test different facets of competence.
Okay, pillar 1.
First, you have the virtual OSCE Objective Structured Clinical Examination. This involves 20 stations. Each one is worth 5 marks, and you only get a highly compressed 4 minutes per station.
4 minutes?
Wow, that totals 100 marks. And it primarily assesses that rapid visual data interpretation and critical triage skill we talked about.
Okay, pillar 2.
Second is the traditional core, the clinical case component. This means 2 real clinical cases, 50 marks each for another 100 marks. This is where you need sustained engagement, in-depth history-taking, physical examination skills, and, explaining your diagnostic rationale over a longer period.
Got it. Third.
The third pillar is the ward round. This tests practical management, prioritization, and communication skills, basically simulating a real ward round. There are 4 short ward rounds, 10 marks each, totaling 40 marks.
Quick checks on managing patients on the fly.
Exactly. How you approach patient management in that setting.
And the final pillar?
Finally, we have the Viva Voce. This is 4 distinct Viva stations, 15 marks each, totaling 60 marks. These are focused, knowledge-based oral tests. They really force the candidate to instantly synthesize complex, evidence-based information and articulate it clearly to an examiner.
Okay, 4 distinct components. And the pass mark.
The crucial threshold is non-negotiable.
Yeah.
You need a minimum of 150 out of the aggregate 300 marks to qualify. That's 50% overall. But you have to achieve it across all these varied and pretty rigorous components.
Managing the timeline on exam day seems absolutely vital. It's highly structured, very intense. Candidates need to report and assemble between 8:00 a.m. and 8:30 a.m.
Yeah, that initial 30 minutes is critical. It's for attendance checks, but also just for candidates to mentally settle in, prepare themselves.
Then what happens?
The next half hour, from 8:30 a.m. to 9:00 a.m., is equally important. This is dedicated to the mandatory candidate briefing, distribution of those barcoded answer sheets and essential checks, roll numbers, station numbers, all that admin.
So you can't start the actual clinical testing without getting that sorted.
No, that administrative foundation has to be in place first.
Okay, so looking at that prep time, we can frame our first little challenge for the listener based on the structure.
This is good.
MCQ1, structural focus. What is the total time allotted for the mandatory candidate briefing and preparation before the virtual OSCE begins? Is it A, 30 minutes, B, 45 minutes, C, 60 minutes, or D, 90 minutes?
Thinking about the breakdown, the correct answer there is C, 60 minutes.
And the explanation is just adding those two slots together.
Precisely. The 60 minutes covers the 30 minutes for reporting and assembly, that's 8:00 to 8:30 a.m., plus the next 30 minutes for the formal briefing and answer sheet distribution from 8:30 to 9:00 a.m. The candidate absolutely must be ready to start the actual exam content right at 9:00 a.m.
Okay, once that admin hour is done, the pressure really starts. The virtual OSCE kicks off at 9:00 a.m. and runs intensely for 90 minutes, right? Until 10:30 a.m.
90 minutes of high-speed diagnosis, yeah.
Is there any break after that?
There is. A brief, but I imagine very necessary pause. A tea break from 10:30 a.m. to 10:45 a.m. Just 15 minutes.
Candidates probably need that time just to regulate their heart rate, shift gears mentally.
Absolutely. Because immediately after that, the deepest, most sustained component begins.
Which is the clinical case exam, running from 10:45 a.m. all the way to 1:30 p.m. That's what, nearly 3 hours?
Almost 3 hours, yeah. Testing those sustained clinical skills, both physical and verbal interaction.
Then lunch?
A brief lunch break is scheduled, 1:30 p.m. to 2:00 p.m., just half an hour. Then the afternoon is dedicated to consolidating and articulating knowledge.
That's the ward round and Viva Voigt components.
Right. Those run together in a block from 2:00 p.m. until 5:30 p.m.
Wow, that's a long afternoon session, too.
It is. And the high drama of the day finishes with the result compilation, which happens remarkably quickly, from 5:30 p.m. to 6:00 p.m.
That quick turnaround suggests the marking process must be pretty rigorously standardized.
Has to be. And we absolutely must emphasize the security measures here. The source material makes a big point about mobile phones, smart watches, any electronic communication gadgets.
Gotta hand them over.
Yes. Switched off and handed over to the invigilators before the exam even starts. This is paramount for maintaining the integrity of an assessment that's run simultaneously across potentially dozens of centers, all controlled by the NBEM's command center. That's the National Board of Examinations and Medical Sciences Central HUD.
Makes sense. Keeps everything fair. Okay, let's focus intensely now on this virtual OSCE, because this seems like where the real speed challenge lies. The logistics sound meticulous. Candidates are seated in a hall, minimum 1 meter distance apart, and they get those 20 barcoded answer sheets beforehand.
Right. And the key structural difference from, say, older exam formats is that there is absolutely no requirement for candidate movement.
So the system rotates the questions to you. You don't run around the room.
Exactly. The system rotates the questions electronically, not the people physically. This eliminates wasted time moving between stations, reduces disruption, and crucially, guarantees the entire duration is spent on intellectual engagement with the material.
And accountability sounds incredibly high, too. The invigilation process requires one of the 4 clinical examiners present to physically sign each answer sheet.
Yep. They act as an invigilator for that particular batch of papers. It creates a powerful layer of individual tracking, ensures every single piece of documentation is accounted for and verified. It's quite rigorous.
And the whole thing is centrally controlled.
The entire virtual OSCE, yes. All 20 stations are run simultaneously across all participating centers. It's done via screen sharing on a video conferencing platform, managed directly from that NBEM's command center we mentioned.
So every candidate sees the exact same image, the exact same question at the exact same moment.
Precisely, which is absolutely vital for standardization in an exam like this.
Now, it's important to remember, this virtual format is relatively new, right? It was kind of forced by circumstance by the pandemic.
That's right. We should look at the evolution briefly. The OSCE concept was initially introduced by NBEMS in 2021, but that was as a physical traditional exam.
Okay.
That earlier format actually featured 25 stations, each worth 6 marks, totaling 150 marks for that component. It was more focused on assessing conceptual understanding through physical interaction and verbal response at stations.
Let's just test that historical fact with our next MCQ then.
For sure.
MCQ2, historical fact. How many stations were originally included in the 2021 introduction of the traditional non-virtual OSCE component? Was it A, 20, B, 25, C, 30, or D, 40?
Okay, the original 2021 format, that would be B25.
25 stations, so the virtual format is actually fewer stations, but maybe more intense per station.
Possibly. Since the shift in 2022 to the virtual OCE, the format has settled into the current 20 stations at 5 marks each, for a 100-mark total. But yeah, that initial blueprint required the stamina to manage 25 distinct physical stations.
How does the virtual mechanism actually work on screen?
Well, the questions are shared via screen sharing. They might span one or more slides, which means the candidate has to absorb potentially several images, maybe an ECG, an echo loop, a CT slice, plus a chunk of text describing the scenario, all pretty much simultaneously within that 4-minute window.
Is there any break during the 20 stations?
There is one brief reprieve. A 4-minute rest period is provided after the first 10 stations. Just allows a moment to maybe stretch, clear your head, refocus before the second half begins.
And what happens with the answer sheets physically?
Logistically, candidates have to keep the filled answer sheets for each station separate and clearly numbered. They only collect them all together right at the end, upon completion of the full 20-station component.
So you can't go back and change an answer for station 3 when you're on station 15?
Exactly. It prevents candidates from going back and altering answers once the time has been called on a specific station. Maintains the integrity of that time pressure.
Yeah. Okay, this brings us to the general instructions. And for me, this highlights the psychological pressure cooker element. Candidates have to sign, fill in roll numbers, station numbers before the exam starts. But the most brutal rule seems to be this one. Questions, once completed, will not be shown back or repeated after the 4-minute time has lapsed.
That rule is, yeah, it's brutal, but I think it's necessary. It's a test of triage under intense psychological duress. 4 minutes is literally all you get for everything read, interpret, think, write.
No going back.
No going back. It forces the candidate to instantly identify the core diagnostic question, rule out the immediate red flags, formulate the key management step, and get it down on paper. It's an intellectual sprint.
Kind of like real life in the ER.
It really mirrors that urgent triage required in a busy emergency department when you're facing a life-threatening complex presentation. Think about it. If you spend 3 of your 4 minutes trying to identify some really subtle finding on ECG, you only have 1 minute left to actually formulate and write down maybe 3 separate answers to the questions asked. That's often where candidates can stumble, not necessarily on the core knowledge, but on managing that incredibly tight time pressure.
Okay, moving past the rapid-fire screening of the OSCE, we hit the clinical exam component. This sounds like the deep dive into real-world medicine. It runs from 10:45 a.m. to 1:30 OP.
Yes, this component is absolutely fundamental because it assesses that core competency of actual patient interaction. The guide emphasizes the use of 2 real clinical cases, each worth 50 marks.
Real patients, not actors or simulations.
Exactly. Real patients with all their complexities, their variable presentations, maybe communication challenges. That emphasis on reality is critical here.
And the time allocation reflects that depth.
It does. Candidates get a substantial 30 minutes per case, specifically just for history taking and physical examination. Based on that initial work, they're expected to generate a primary differential diagnosis and a management plan.
Okay, so 30 minutes with the patient, then what?
Then comes the examination by the examiners. This part lasts approximately 15 to 20 minutes per case. This is where the synthesis happens. The candidate have to articulate their findings, defend their differential diagnosis, justify their management strategy.
And who assesses this?
The assessment structure is quite intimate. A pair of examiners assesses one clinical case together. This ensures a focus and deep evaluation of that interaction.
Okay, after the long cases, we hit the ward round component in the afternoon block. This sounds like it focuses entirely on practical management and prioritization.
That's exactly right. It reflects the daily responsibilities of a consultant or specialist on the wards.
How's it structured?
4 specialized ward rounds, 10 marks each, adding up to 40 marks total. These are designed to be quick, focused encounters, about 8 to 10 minutes per patient or scenario.
Short and sharp.
Very. And crucially, candidates face all 4 different examiners during this component, so you're assessed by everyone.
Ensures a broad assessment perspective.
Definitely. You might face an academic specialist, then a clinician known for therapeutics, maybe one focused on complex systems. It demands flexibility in how you present your patient management strategy. And again, the source emphasizes using real patients for this too.
Makes sense. Finally, the Viva Voce component, testing knowledge synthesis and communication. 4 Viva stations, 15 minutes per station, you said.
Right, 4 stations, 15 minutes each. The total value here is 60 marks for this component.
And the logistics.
The structure of the Viva is highly controlled, mainly for security and focus. Candidates typically enter in batches of 4, and isolation or segregation is mandatory for those who have finished their station. They can't mix with those who are still waiting to prevent any information leakage.
Fair enough. Let's lock down the value of this component with an MCQ.
Okay.
MCQ 3, Viva structure. How many marks are assigned to each individual Viva Voice station? A, 10, B, 15, C, 20, or D, 25?
Okay, 4 stations totaling 60 marks means each one must be worth B, 15 marks.
15 marks. Okay, that confirms the Viva Voce is a significant chunk of the total score. Candidates need to treat each 15-minute station pretty seriously.
Absolutely. And to illustrate the kind of depth required, the source material actually gives us a clear template from the cardiology domain. It shows how the knowledge is broken down for comprehensive testing in the Viva.
How's it segmented?
The Viva Voice stations, at least in cardiology, are explicitly segmented into 4 distinct areas. First, A, coronary artery disease testing, core pathophysiology, interventions, that sort of thing.
Standard stuff.
Second, B, congenital heart disease testing knowledge of complex structural defects, often involving both pediatric and adult congenital issues.
More specialized.
Third, C, arrhythmias and pacemaker devices testing EKG interpretation, device function, troubleshooting, management algorithms.
Who's techie?
And fourth, D, recent advances in landmark trials in cardiology. This is the forward-looking section, ensuring the candidate is completely current with the latest evidence-based medicine, the big trials that change practice.
Wow, so it's not just rote knowledge. You absolutely have to command specialized technological knowledge and be on top of the very latest clinical evidence.
That's the standard. It's comprehensive.
Okay, before we jump into the actual clinical station examples, let's just quickly touch on the administrative side again. The sample answer sheet shown in the guide. It looks generic, but it demands absolute accuracy, right? Test center name, roll number, station number, specialty, and those signatures, candidate and invigilator.
Absolutely critical. You could be the best clinician in the world, but if you mess up the administrative details in a high-stakes environment like this, it can cause major problems. Accuracy is paramount, even here.
Okay, admin sorted. Let's get into the clinical meat, starting with what looks like the highest stakes presentation. Demo station 1.
Right, the unstable patient.
Scenario. A 45-year-old male comes in with palpitations, had them for 30 minutes. His blood pressure is critically low, 80, over 50 millimole HD. He's in shock. And an ECG is shown, which, given that instability, must show something pretty life-threatening, right? A rapid arrhythmia.
Almost certainly. So Q1 asks for the diagnosis. The key here is to immediately recognize the context of the arrhythmia. It's not just any tachycardia. It's an unstable tachyarrhythmia.
Because of the shock.
Because of the shock.
Yeah.
The underlying rhythm might be ventricular tachycardia, VT, maybe atrial fibrillation with a really rapid ventricular response causing this decompensation. But the primary diagnosis is unstable tachyarrhythmia.
Okay, so Q2, the absolutely critical question, what is the first step of management?
Given the clear evidence of shock, that systolic BP under 90, likely altered mental state, the answer has to be immediate synchronized electrical cardioversion.
No messing around with drugs first.
Absolutely not. There is simply no time for drugs when the patient is this unstable. The source material and all guidelines emphasize that hemodynamic instability dictates immediate electrical intervention.
Okay, let's push on that. What if a candidate, maybe panicking a bit, thinks, oh, cardioversion needs sedation, that takes time, and they instinctively reach for IV amiodarone or something?
That's the exact pitfall this question is designed to catch. In the face of shock, trying slow, pharmacological measures first is potentially fatal. Electrical cardioversion delivers energy instantly. A drug bolus takes minutes to infuse, circulate, and hopefully take effect.
Minutes the patient doesn't have.
Exactly, minutes the patient's brain and heart don't have. That's why the rule is often drilled in as, if unstable, the answer is electricity. Shock the shock.
Got it. And Q3 asks the candidate to name one complication of the management itself. This forces a shift from just fixing the rhythm to thinking about safety.
Right. You've done the urgent thing, now what are the risks? Complications of cardioversion can include things like skin burns at the pad sites, sometimes precipitating more complex arrhythmias after the shock, and a really important one. If the patient have underlying AF and hasn't been adequately anticoagulated, there's a risk of systemic thromboembolism. You need to be aware of that.
Okay, let's shift gears. Demo station 1A1B moves us into chronic infectious disease and imaging scenario. A 35-year-old male, he's had a fever for a month, cough with sputum for 10 days, and then just 1 day of coughing up blood hemoptysis. A chest x-ray is shown.
Classic presentation. Q4 demands structured radiological interpretation. Name 4 findings on the chest X-ray. The candidate needs to systematically describe what they see. Maybe consolidation, maybe cavitation, which is crucial for things like TB, perhaps hilar lymphadenopathy, any signs of pleural effusion, volume loss. A structured read.
Okay. Q5 asks for the diagnosis. Given that history, the chronic fever, cough, hemoptysis, and often you'd expect characteristic upper lobe findings on the image. What's the likely diagnosis?
The most likely diagnosis here is active pulmonary tuberculosis, TB. The duration, particularly the 1 month of fever, is a key factor pointing away from a simple acute bacterial pneumonia.
Right, and Q6 pushes beyond the obvious. Give 2 differential diagnoses based on the CXR finding. So what else could cause similar X-ray changes, especially cavitation or prolonged fever?
Good question. You need to think broader. Things like a lung abscess, certain fungal infections, maybe histoplasmosis, aspergillosis, or even, though less common in this age group perhaps, an advanced necrotizing lung cancer could present this way.
Okay, now Demo Station 2 jumps into acute, very time-sensitive neurology scenario. A 55-year-old man presents with acute onset left hemiparesis, weakness down the left side. It started 12 hours ago. A brain CT scan is shown.
12 hours duration is key. Q1 asks for the finding and diagnosis. If it's an acute ischemic stroke, the non-contrast CT might initially show very subtle signs, maybe early edema causing hypodensity, a loss of gray-white differentiation in the affected area. The diagnosis would be acute ischemic stroke, and ideally specify the territory, like right middle cerebral artery, MCA territory, causing left weakness.
Okay, then Q2 asks the absolutely critical question, is he a good candidate for intravenous thrombolysis, the clot-busting drug?
And the answer, based purely on the time provided, has to be no.
Why no? 12 hours too late.
Yes. The standard therapeutic window for 5E thrombolysis, using drugs like alteplase, is generally accepted as 4.5 hours from the onset of clear symptoms. 12 hours is well outside that window.
Let's elaborate on the clinical reasoning, though. Why is that window so strict?
It's all about the risk-benefit balance. Within the early hours, the benefit of dissolving the clot and restoring blood flow potentially outweighs the risks. But as time goes on, the brain tissue supplied by that blocked vessel becomes irreversibly damaged, infarcted.
Okay.
Trying to lyophilize the clot and reperfuse that damaged area later significantly increases the risk of hemorrhagic transformation. Basically, the reperfusion injures the already weakened blood-brain barrier, turning the ischemic stroke into a potentially catastrophic bleeding event. Outside 4.5 hours, that risk generally outweighs the potential benefit for 5E lysis.
But wait, for our listeners who follow the latest guidelines, isn't there sometimes a role for more advanced imaging like CT perfusion or MRI to potentially push that window for select patients? Is the exam testing the basic rule or the cutting edge?
That is an excellent point, and it highlights the depth that might be expected from a top candidate. While the standard answer based on time alone is no, a really strong candidate might qualify that.
How?
They could mention that current advanced stroke protocols do allow for an extended treatment window, sometimes up to 24 hours, for mechanical thrombectomy, physically removing the clot if there's a large vessel occlusion. And for 4V lysis itself, some very selected patients might be candidates beyond 4.5 hours if advanced imaging, like DVI flare mismatch on MRI or specific CT perfusion profiles, demonstrates a significant amount of salvageable brain tissue, the penumbra.
Okay.
However, in the context of a rapid-fire 4-minute OSCE station, the safest, most direct, and generally expected answer focusing on IV thrombolysis based on the 12-hour history alone is no. The question primarily tests knowledge of that standard time contraindication. Mentioning the advanced options would be bonus points, showing deeper knowledge.
Okay, makes sense. Q3 then moves into surgical management. What surgical procedure may be required?
In cases of severe ischemic stroke, particularly involving the MCA, if the patient develops massive cerebral edema, what's often called malignant MCA syndrome, causing significant midline shift on imaging and threatening to crush the brainstem, the life-saving procedure is an urgent decompressive craniectomy. Removing a large flap of the skull allows the swelling brain room to expand outwards, relieving the pressure.
Drastic, but life-saving.
Can be. And finally, Q4 focuses on prevention. What medication may be required to prevent recurrence? Now we're talking secondary prevention. This typically involves antiplatelet agents like aspirin, clopidogrel, or maybe dual therapy for a period, or If the stroke was cardioembolic, say, from atrial fibrillation, then therapeutic anticoagulation would be needed. Plus, aggressive management of risk factors: hypertension, diabetes, high cholesterol, smoking cessation.
Right, the long-term game. Let's bring in our second case example here, applying this acute management thinking. We'll call it the tachycardia triage. Case example 2, the tachycardia triage. Imagine a new nurse working in a busy emergency department. A patient comes in complaining of severe palpitations. The nurse sees a rapid heart rate on the monitor, maybe 180 BPM, and panics slightly. Their first instinct is to grab an antiarrhythmic drug, maybe amiodarone, thinking they need to fix the rhythm pharmacologically. They're worried about the time it takes to prepare for cardioversion.
Understandable initial reaction for someone less experienced, perhaps.
But then a senior resident steps in. They glance at the vital signs monitor and point out the patient's blood pressure. 80/50 millimilli Hg. Critically low.
The game changer.
Instantly, the priority shifts. The resident explains that while fixing the rhythm is important, the instability caused by the low BP is the immediate life threat. The priority shifts from a potentially slow pharmacological conversion to the immediate need for electrical conversion.
Right. Sedate and shock.
The resident emphasizes that clinical stability, reflected primarily by the blood pressure and mental status, is the single most important decision point in the acute management of any tachyarrhythmia.
Perfect summary. The practical application is crystal clear. Hemodynamic instability, that shock state, is the immediate overriding indication for electrical intervention. It trumps standard medication protocols in that acute moment. Get the pressure up, perfuse the brain, then worry about the long-term rhythm management.
Okay, we move now into the actual numbered clinical stations, the core of the OSCE. Let's look at the first block, stations 1 through 10, often grouped thematically. It looks like adult cardiology features heavily here rhythm and structure issues.
Seems so. Let's start with station 1, syncope, ECG, echo. The scenario is a 45-year-old man. He's had syncopal episodes, fainting, and his ECG shows complete heart block, CHB. An echocardiogram is also shown.
Classic presentation linking symptom, ECG finding, and needing a solution.
Exactly. The questions likely probe the etiology of the CHB. Why would a relatively young man have this? Could be degenerative fibrotic disease of the conduction system, like Lenegre's disease, maybe congenital, maybe inflammatory, like Lyme disease, or even drug-induced. The echo might give clues about structural heart disease.
And the management question.
Investigations would likely include things like a Holter monitor to see the burden of the block and look for other arrhythmias. But Q3, the core management question for symptomatic CHB, as we've established, is definitive: permanent pacemaker implantation. The syncope makes it mandatory.
Okay, makes sense. Now let's immediately pivot to a very different scenario in station 2, neonatal cyanosis. A 2-day-old child, centrally cyanosed, blue lips, tongue, oxygen saturation is low at 70%. An echocardiogram is shown.
High-stakes pediatric cardiology. This tests rapid neonatal triage. Q1 asked for 3 broad causes of cyanosis at birth. A good candidate needs a systemic approach here. Like cardiac causes, specifically cyanotic congenital heart disease. Pulmonary causes severe respiratory distress syndrome, RDS, persistent pulmonary hypertension of the newborn, PPHN, or even central nervous system causes maybe a severe seizure disorder or intracranial hemorrhage causing profound hypoventilation and secondary cyanosis.
What's the critical skill being tested there beyond just listing causes?
It's differentiating pulmonary from cardiac causes, urgently. Why? Because if the cause is a duct-dependent cardiac lesion thing, transposition of the great arteries, TGA, pulmonary atresia, critical coarctation where systemic or pulmonary blood flow relies on the ductus arteriosus staying open, you must immediately initiate prostaglandin E1, PGE1 infusion to keep that duct open. Failure to recognize that urgent need and start prostaglandins promptly is a major, potentially fatal error. That's the hidden test.
Got it. Q2 then links the cardiac anomalies shown on the echo to potential genetic abnormalities.
Right. Depending on the specific lesion shown, the candidate might need to list things like Down syndrome, trisomy 21, often associated with atrioventricular septal defects, AVSD, or DiGeorge syndrome, 22q11 deletion, associated with truncus arteriosus, tetralogy of Fallot, TOF, interrupted aortic arch, maybe Turner syndrome for coarctation.
Okay. And Q3 and 4 ask for the specific diagnosis from the echo and potential surgical options.
Yeah, so if the echo showed, say, tetralogy of Fallot, TOF, the diagnosis is TOF. Surgical options might include an initial palliative shunt procedure, like a Blay-Octosic shunt, followed by a later complete repair. If it was TGA, you might need an urgent balloon atrial septostomy rash-kind procedure followed by an arterial switch operation. The specifics depend entirely on the image provided.
Complex stuff.
Mm.
Okay, station 3. Drowsiness, breathlessness, shock. Back to the acute adult emergency. A 56-year-old man brought into the emergency room, drowsy, breathless, pulse, and BP are non-recordable. He's in profound shock or cardiac arrest. An ECG is shown.
The ECG likely shows something like pulseless electrical activity, PEA,
Right.
a systole, or perhaps an extreme bradyarrhythmia causing the collapse. Q1, the diagnosis is clearly cardiogenic shock, cardiac arrest.
Q2 asks for the immediate action.
No hesitation. Start CPR immediately and follow the Advanced Cardiac Life Support ACLS protocol. Call for help, high-quality chest compressions, airway management, rhythm analysis.
And Q3 asks about treatment agents and considering treatable causes.
The primary pharmacological agent in most ACLS arrest algorithms is epinephrine, adrenaline. But the really sophisticated part of the answer requires the candidate to immediately think about and list the potentially reversible causes of cardiac arrest, the classic H's and T's.
Remind us.
Hypovolemia, hypoxia, hydrogen ion acidosis, hyperkalemia, hypothermia, and the T's, tension pneumothorax, tamponade cardiac, toxins, thrombosis, pulmonary or coronary. You have to actively look for and treat these during the resuscitation attempt.
Okay. Station 4, device identification. This sounds like a pure test of specialized hardware knowledge. Identify all the devices implanted in a patient, probably shown on an X-ray or CT.
Exactly. This tests the ability to spot the sometimes subtle differences. For example, recognizing a thick coiled lead, typically seen in the right ventricle, or RV, that signifies an implantable cardioverter defibrillator, VCD coil, designed to deliver a shock. That's different from a thinner, maybe screw-in or tine lead used just for standard pacing. Or identifying coronary stents, annuloplasty rings from valve surgery, prosthetic valves. You need to know what they look like.
Got it. Station 5, chest discomfort, dyspnea, specific ECG. A 45-year-old man, chronic symptoms, chest discomfort, and shortness of breath for 6 months. Vitals are stable. An ECG is shown, likely with characteristic features.
The ECG might show things like prominent T-wave inversions, particularly in the precordial leads, or signs of significant left ventricular hypertrophy, LVH. Q1 and 2 ask for the diagnosis and the syndrome name. Given the chronic symptoms and typical ECG echo findings, likely shown or described, this strongly points towards hypertrophic cardiomyopathy, HOCM.
Okay. And Q3 asks for typical echo findings and maybe a special modality.
Typical echo findings in HOCM include asymmetric septal hypertrophy, the septum muscle is much thicker than the posterior wall, and potentially systolic anterior motion, SAM, of the mitral valve, where the valve leaflet gets pulled into the outflow tract, causing obstruction. Special modalities might include using tissue Doppler imaging to assess diastolic function, or sometimes contrast echocardiography to better delineate the apex, which can be involved.
Right. Station 6, excruciating chest pain, hypertension. This sounds dramatic. A 48-year-old man, excruciating chest pain radiating straight through to the back, profuse sweating. ECG is initially unremarkable, but his BP is sky high. 200 and 150 mmHg, a hypertensive emergency. An echo is shown, likely revealing the cause.
That history-tearing pain radiating to the back, severe hypertension, is the absolute classic presentation for acute aortic dissection. The echo might show a dilated aortic root, an intimal flap, or pericardial effusion if it's ruptured into the pericardium.
Okay. Q1 asks for the indication for urgent intervention. What's the priority?
The immediate indication is stabilization. Aggressive, rapid control of the heart rate and blood pressure is paramount for definitive diagnosis and intervention. The target is often a systolic BP around 120 mmHg and a heart rate below 60 BPM. This reduces the shear stress on the damaged aortic wall.
Control the hemodynamics first.
Absolutely. Then confirm the dissection type. Type A involving the ascending aorta, or type B confined to the descending aorta, usually with a CT angiogram. Urgent surgical repair is typically indicated for type A dissections. Medical management is often the first line for uncomplicated type B.
Let's test that priority again, focusing on the hemodynamics with a slight twist.
Okay.
MCQ5, aortic dissection priority. In the acute medical management of a patient with suspected aortic dissection and severe hypertension, which parameter is generally considered the most immediate target to control aggressively? A, reducing diastolic blood pressure below 90. B, lowering heart rate to below 60 BPM. C, achieving pain control with morphine. D, normalizing serum creatinine.
Most immediate target. While all are important eventually, the primary goal to reduce aortic wall stress is lowering both heart rate and blood pressure. But the key is reducing the force of ejection. DPDT. So B. Lowering heart rate to below 60 BPM, usually with beta blockers, is often prioritized or done concurrently with BP lowering because it directly reduces that shear stress.
Right. Beta blockers first, then maybe vasodilators if needed.
That's the typical strategy. Reduce the heart rate and contractility first.
Okay. Q2 asks about the latest therapeutic techniques.
For type A, it's still primarily open surgical repair. But for complicated type B dissections, like malperfusion or rupture, thoracic endovascular aortic repair, TEVAR, placing a covered stent graft via catheter, has become a major technique.
And Q3 asks for complications.
Devastating ones. Aortic rupture, malperfusion syndrome, where the dissection flap blocks off blood supply to limbs, gut, kidneys, spine, stroke, acute severe aortic regurgitation if the valve is involved, very high mortality if not treated quickly.
Okay. Station 7, device and history. This sounds similar to Station 4, but maybe with a historical angle. Identify a specific medical device, perhaps an early version of an ICD, or maybe a Doppler ultrasound probe.
Could be. Q2 then asks, who first described its use? This requires some knowledge of medical history of the pioneers in the field.
And Q3 brings in a practical angle, advantages and disadvantages in resource-limited settings.
Yes, this is an excellent question. Testing practical applicability beyond just the high-tech environment. Does this device need constant expensive maintenance? Is it robust? Does it require highly specialized training that might not be available everywhere? It forces the candidate to think about cost-effectiveness and global health equity.
Important considerations. Station 8, child seizures, family history, ECG. This one sounds worrying. A 2-year-old child presenting with recurrent episodes described as seizures. Crucially, there's a family history of seizures, and an uncle died suddenly at age 26. A telemetry ECG strip is shown.
That family history of sudden death in a young relative is a massive red flag. The seizures in the child are very likely not epileptic seizures, but rather syncopal episodes caused by a dangerous cardiac arrhythmia. The ECG probably shows the underlying cause.
Like what?
Given the history, the ECG likely shows evidence of an inherited cardiac channelopathy, most commonly congenital long QT syndrome, OQTS, or possibly Brugada syndrome, or catecholaminergic polymorphic VT, CPVT.
So Q1 asks for diagnosis and treatment drugs. Diagnosis is likely LQTS or similar. Treatment.
For LQTS, the mainstay of treatment is beta blockers, like nadolol or propranolol, to prevent arrhythmias triggered by adrenergic surges. Avoiding QTC prolonging drugs is critical. In high-risk cases, an ICD might be needed. For CPVT, beta blockers plus flecainide might be used.
Q2 asks for ominous signs and precipitants.
Ominous signs on the ECG or during an episode would be torsades de pointe, the characteristic twisting polymorphic VT seen in LQTS, or sustained VTBF. Precipitants depend on the specific LQTS type. Strenuous exercise, especially swimming for LQT1, sudden loud noises or emotional stress, LQT2, or sometimes even sleep, LQT3. Recognizing these triggers is vital for patient advice.
And Q3 asks for other causes of such an ECG abnormality, like a long QT interval.
Important to consider acquired causes too: electrolyte disturbances, low potassium, low magnesium, numerous medications, antiarrhythmics, antibiotics, antifungals, psychiatric drugs, or even ischemia can prolong the QT interval.
Okay. Station 9, device identification, contraindications, complications. Similar to Station 4 and 7, identify a specific device, maybe a particular type of cardiac catheter or an older model ICD.
Right. Q2 and 3 then ask for specific contraindications and complications associated with that device or the procedure it's used for. This requires detailed knowledge. For example, contraindications for a certain catheterization procedure, or complications like lead dislodgement or infection for an implanted device.
And Q4 asks to name other devices used for similar purposes, tests knowledge of the alternatives, the technological landscape.
Exactly. Comparative technology analysis.
Let's solidify a point about device contraindications with an MCQ, maybe focusing on pacing technology again.
Go for it.
MCQ 6, pacing technology. Which of the following clinical scenarios represents the strongest relative or absolute contraindication for implanting a standard non-MRI conditional permanent pacemaker system? A, patient has severe chronic kidney disease. B, patient has well-controlled diabetes mellitus. C, patient has a high likelihood of needing future thoracic surgery. D, patient has a clear ongoing clinical need for serial surveillance cardiac MRI scans.
Okay, strongest contraindication for a non-MRI conditional pacemaker. That would clearly be D. Patient has a clear ongoing clinical need for serial surveillance cardiac MRI scans.
And the reasoning.
The powerful magnetic fields and radiofrequency energy used in MRI can cause significant issues with older, non-conditional pacemakers, heating of the leads, unpredictable pacing or inhibition, device damage. If MRI is essential for managing another condition, you'd strongly favor an MRI conditional system or explore alternatives. While thoracic surgery needs consideration, it's not usually an absolute contraindication, and CKD diabetes aren't direct contraindications to the device itself.
Makes sense. Finally, in this block, patient 10, dyspnea, murmur, echo. A 35-year-old lady, class 2 dyspnea, short of breath on moderate exertion for 4 months. She has a pansystolic murmur, heard throughout systole, and is hemodynamically stable. An echo is shown.
That murmur description strongly suggests middle regurgitation, MR, or possibly tricuspid regurgitation, but given the dyspnea, MR is more likely causing symptoms. The echo likely confirms severe mitral regurgitation.
So Q1 asks for the complete echo diagnosis. What does that involve?
More than just saying severe MR. It means quantifying the severity, using measures like vena contracta with EROA, regurgitant volume, identifying the mechanism, e.g. leaflet prolapse, flail leaflet, restricted motion due to rheumatic disease or ischemic changes, assessing the impact on left ventricular size and function, LVEF, LV dimensions, and estimating pulmonary artery pressures.
A full picture. Q2 asks for an ominous sign and its harbinger. What would be worrying in severe MR?
An ominous sign, even in an asymptomatic patient, would be the onset of left ventricular dysfunction, for example, the LVEF starting to drop below 60%, or the LV end systolic dimension increasing beyond a certain threshold, e.g. 40-45 millimeter. Another ominous sign is the development of significant pulmonary hypertension. These often harbingers a worse prognosis if the MR isn't corrected.
And Q3 directly asks for indications of surgery, mitral valve repair or replacement.
This tests guideline knowledge. Indications typically include any symptomatic patient with severe MNRs, asymptomatic patients with severe MR if there's evidence of LV dysfunction, LVEF 60% or LVESD 40 millimeters. Also, asymptomatic severe MR if there's new onset atrial fibrillation or pulmonary hypertension, systolic pressure 50 millimil Hg. Repair is generally preferred over replacement if feasible. Okay, after those 10 intense clinical stations, we hit the midpoint, and appropriately, station 11 is designated as a rest station.
A rest station? What happens there? Do you just sit in silence?
Not quite. It's designed to give the purely clinical parts of the brain a slight break, but it still tests something, usually general knowledge or recognition relevant to the field.
How?
The typical format asks the candidate to identify famous personalities, labeled A, B, C, D, maybe from photographs, and state the reason for their fame within medicine, or specifically within their specialty, like cardiology.
So it tests intellectual curiosity, knowing the history, recognizing key figures who shaped the field.
Exactly.
Nah.
You might see images of someone like Werner Forsman, who we know performed the first human cardiac catheterization on himself, or maybe René Laennec, the inventor of the stethoscope, or perhaps pioneers of specific procedures or landmark trials. It ensures the candidate has some grounding in the history and context of their specialty.
Interesting. It's a different kind of knowledge being tested. Let's test our listeners' historical knowledge right here then.
Good idea.
MCQ 7, historical figures. Which renowned medical figure is primarily credited with performing the first self-catheterization of the human heart, demonstrating the feasibility of the technique in 1929? A. William Harvey, described circulation. B. Werner Forsman. C. Andreas Vesalius, anatomist. D. Christian Barnard, first heart transplant.
That has to be B, Werner Forsman.
Correct. Forsman's incredibly audacious self-experiment, threading a catheter up his own arm vein into his heart, really laid the entire groundwork for modern interventional cardiology and earned him a Nobel Prize much later. It's a reminder that even the most high-tech procedures often have a bold, singular, sometimes slightly crazy historical beginning.
All right. Rested and perhaps slightly cultured, we move into the second block of OSCE stations, 12 through 20. These often delve into more advanced or nuanced clinical scenarios.
Okay, like station 12, chest pain, hypotension, normal angio. This sounds like one of those classic test the differentials questions. A 50-year-old woman, sudden chest pain, sweating, she's hypotensive, systolic BP 80 millimilli Hg. Her ECG looks bad, maybe showing ST elevation or deep T-wave inversions, mimicking a heart attack. But then, crucially, her coronary angiogram is completely normal. An LV angiogram, or echo, reveals a specific shape, often described as apical ballooning.
The diagnosis here is almost certainly Takotsubo cardiomyopathy, also known as stress cardiomyopathy or broken heart syndrome.
Why Takotsubo?
The clinical hallmark is this presentation. Acute, severe cardiac symptoms, often including hemodynamic compromise like shock, ECG changes mimicking MI, elevated cardiac enzymes, but with angiographically normal coronary arteries. The characteristic apical ballooning shape of the left ventricle during systole confirms it.
Okay. Q2 then challenges the candidate to think broadly about MINOCA, which stands for myocardial infarction with non-obstructive coronary arteries. What are four key differentials besides Takotsubo?
This is important because MINOCA isn't a single entity. Besides Takotsubo, the candidate needs to consider myocarditis, inflammation of the heart muscle, coronary artery spasm, like Prinzmetal's angina, coronary embolism, a clot traveling from elsewhere, and sometimes severe supply-demand mismatch, classified as a type 2 MI. Differentiating these often requires further imaging, like cardiac MRI or specific clinical clues.
Q3 asks about the derivation of the name Takotsubo.
Right, the cultural knowledge bit. The shape of the left ventricle in systole during the acute phase, with the apex ballooning out and the base contracting normally, resembles a traditional pot used by Japanese fishermen to trap octopus. That pot is called a takotsubo.
Interesting. And Q4 asks for four potential complications. Can Takotsubo be serious?
Absolutely. Despite often being reversible over weeks or months, takotsubo can be lethal in the acute phase. Complications include cardiogenic shock, as in this case, formation of a ventricular thrombus in the stunned apex, requiring anticoagulation, rarely ventricular rupture, and unfortunately, recurrent episodes can occur in some patients.
Okay. Station 13, device technology. Similar theme again. Identify a specific device. Maybe this time it's a catheter used for thrombolysis or perhaps an IVC filter.
Could be. Q2 asks for various uses of that technology. So if it's a thrombolytic catheter, uses are clot management in arteries, veins, grafts. If it's an IVC filter, it's preventing pulmonary embolism. Q3 asks for the basic mechanism. How does it work? Mechanical disruption, drug delivery, filtering.
And Q4 specifically asks for newer techniques for acute pulmonary thromboembolism, PE management. What's cutting edge here?
This is testing awareness beyond just standard anticoagulation or systemic thrombolysis. We're talking about catheter-directed thrombolysis, CDT, where lower doses of a lytic drug are infused directly into the clot via a catheter placed in the pulmonary artery. Also, mechanical thrombectomy devices vary as catheters designed to physically break up or aspirate the clot. These are increasingly used, especially in submassive or massive PE, where systemic lysis might be too risky or has failed.
Got it. Station 14, imaging technique and complication.
2 asks for two fallacies or limitations of the technique shown. For example, if it's angiography, limitations include vessel overlap, making interpretation hard, inability to see the vessel wall or characterize plaque properly, just shows a lumen shadow, foreshortening of vessels depending on the angle.
Okay. Q3 asks about other detectable complications from that imaging.
So if it's an angiogram, you might see complications like coronary dissection caused by the catheter, evidence of plaque rupture, or maybe a coronary fistula. Q4 then asks, when should you treat the condition depicted? Here again, the coronary aneurysm. That requires knowledge of guidelines based on size, location, symptoms, and risk of rupture or thrombosis.
Right. Station 15, ECG evolution and hypotension. Back to acute emergency. A 42-year-old lady, sudden chest pain, severe dyspnea, and she's very hypotensive. BP 70 mmHg systolic. Two ECGs are shown, ECG1 from initial presentation and ECG2 taken 2 hours later, likely showing changes.
That clinical picture, sudden collapse, dyspnea, shock with evolving ECG changes strongly suggests massive pulmonary embolism, PE, causing obstructive shock.
So Q1 diagnosis is massive PE. Q2 asks for typical ECG and 2D echo findings.
For the ECG, the classic, though not always present finding, is the S1Q3T3 pattern. Deep S wave in lead I, Q wave in lead 3, inverted T wave in lead 3. More commonly, you might see new right bundle branch block, RBBB, right axis deviation, or sinus tachycardia. Widespread T-wave inversions in the right bicordial leads, V1, V4, are also suggestive of RV strain.
And the echo.
The 2D echo is crucial for assessing the impact on the right heart. Key findings are signs of RV strain or pressure overload. RV dilatation, RV bigger than LV, paradoxical septal movement, septum flattened or bowing into the LV, possibly visible thrombus in transit, and RV hypokinesis, often sparing the apex McConnell sign.
Let's test the echo finding significance with an MCQ.
Okay.
MCQ 8, PE diagnosis. In the setting of suspected massive pulmonary embolism, which change on a 2D echocardiogram is the most direct and sensitive indicator of acute right ventricular pressure overload? A, left atrial enlargement. B, D-shaped configuration of the interventricular septum bulging into the left ventricle. C, mild mitral regurgitation. D, normal RV size and function.
The most direct mechanical sign of RV pressure overload is B. D-shaped configuration of the interventricular septum bulging into the left ventricle,
Why is that the most sensitive indicator?
because it's a direct consequence of physics. When the pressure in the right ventricle acutely exceeds the pressure in the left ventricle due to the massive blockage in the pulmonary arteries, the septum, which normally bows slightly into the RV, gets pushed across the midline into the LV, creating that characteristic D shape in the short axis view. It's a clear sign the RV is failing against the high pressure.
Makes sense. Station 16, child fatigue, cyanosis, cath findings. Back to pediatrics, but maybe older child congenital. A 2-year-old boy, easily fatigued, increased work of breathing, centrally cyanosed since birth. Cardiac catheterization findings are provided, likely showing very high pulmonary artery pressures and evidence of reversed right-to-left shunting.
This clinical picture, combined with those cath findings, points strongly towards Eisenmenger syndrome.
What exactly is Eisenmenger syndrome? Q3 asks for the components.
Eisenmenger syndrome is essentially the end stage of a large, uncorrected congenital heart defect that caused a left-to-right shunt initially, like a large VSD, ASD, or PDA. Over time, this massive volume pressure overload leads to irreversible changes in the pulmonary arteries, causing severe pulmonary hypertension. Eventually, the pressure in the pulmonary circulation exceeds the systemic pressure, causing the shunt flow to reverse, become right to left. This deoxygenated blood now bypasses the lungs and enters the systemic circulation, leading to cyanosis.
So the key components are underlying large shunt, severe pulmonary hypertension, and reversed right-to-left shunt causing cyanosis.
Exactly, it's a triad.
And Q2 asks for common complications. Is this dangerous?
Very dangerous, unfortunately. Common complications include hemoptysis, coughing up blood due to fragile pulmonary vessels, stroke, often due to paradoxical embolism or polycythemia, brain abscess, sudden cardiac death, arrhythmias, and progressive chronic heart failure. Management is largely supportive and focuses on managing complications.
Okay. Station 17, palpitations while running ECG. More common scenario, perhaps. A 45-year-old man developed palpitations while running, which didn't settle afterwards. He comes to the emergency department, and an ECG is taken, likely showing a regular, narrow, complex tachycardia around 150-220 BPM.
Q1 diagnosis. This is most likely supraventricular tachycardia, SVT, specifically the common types like AV nodal reentrant tachycardia, AVNRT, or AV reentrant tachycardia, AVRT, involving an accessory pathway.
Q2 asks for differentials. What else could cause a regular, narrow, complex tachycardia?
Important to consider others. Atrial flutter, often with a 2.1 block giving a rate around 1 in 50. Atrial tachycardia, sometimes junctional tachycardia. Distinguishing them often relies on subtle ECG features like P-wave morphology or response to maneuvers.
And Q3 asks for pathophysiology and treatment.
Pathophysiology, as mentioned, usually involves a reentry circuit either within the AV node, AVNRT, or using an accessory pathway connecting atrium and ventricle, AVRT. Treatment for an acute, stable episode starts with vagal maneuvers, like Valsalva or carotid sinus massage. If that fails, the first-line drug is intravenous adenosine, which briefly blocks the AV node and often terminates the reentry. If that fails or isn't suitable, IV beta blockers or calcium channel blockers, like verapamil diltiazem, can be used. Long-term catheter ablation of the circuit is often curative.
Okay. Station 18, cardiac procedure. An image is shown depicting a specific cardiac surgical or interventional procedure.
Q1 asks, what is the procedure? Could be anything from a balloon atrial septostomy, Rashkin procedure, placement of a surgical shunt, like a Balak-Taussig, closure of a defect, valve repair, depends on the image.
Q2 asks, what condition requires this procedure, linking the intervention to the disease?
Right. So if it's a Rashkin, the condition is likely TGA needing atrial mixing. If it's a BT shunt, it's usually for conditions with reduced pulmonary blood flow like TOF or pulmonary atresia.
And Q3 asks for other cardiac anomalies typically noted in these patients.
This tests knowledge of associated defects. For example, patients needing a BT shunt for TAFib often have other associated anomalies that might influence surgical planning. It requires understanding the spectrum of congenital heart disease.
Okay. Station 19, STEMI equivalence. An ECG image is shown. Q1 asks for the most likely culprit vessel based on the pattern of ST elevation or other changes.
Standard interpretation. E.g., ST elevation and leads 2, 3, AVF points to the right coronary artery, RCA causing an inferior wall MI. ST elevation in V1, V4 points to the left anterior descending artery, LAD, causing an anterior wall MI.
But Q2 asks for the name of the sign and abnormalities noted. This might be a specific pattern.
Exactly. Could be showing something specific like Wellens sign, which involves deep, symmetrically inverted T waves or biphasic T waves, usually in leads V2 and V3. This pattern often appears when the patient is pain-free, but indicates a critical stenosis in the proximal LAD.
And Q3 asks to enumerate STEMI equivalents. What are those?
STEMI equivalents are ECG patterns that signify an acute coronary occlusion requiring immediate reperfusion therapy like PCI, even if they don't meet the classic ST elevation criteria. Key examples include posterior MI, look for ST depression in V1, V3, often with tall R waves. ECG signs of left main coronary artery occlusion or new left bundle branch block, LBBB, in the context of ischemic symptoms, using Scarbossa criteria to help. Wellens sign itself is often considered an urgent situation needing intervention, though not technically a STEMI equivalent demanding immediate lysis.
Let's lock down Wellens' significance with an MCQ.
Great problem.
MCQ 9, ECG interpretation. What does the presence of Wellens syndrome, type A or BT, changes in V2, V3 on an ECG, typically recorded during a pain-free interval, strongly suggest A, an evolving acute STEMI, B, acute pericarditis, C, critical stenosis of the proximal left anterior descending LAD coronary artery, D, a completed or old inferior wall infarction.
The correct answer is C, critical stenosis of the proximal left anterior descending LAD coronary artery.
And a clinical implication.
It signals an extremely high risk of an imminent massive anterior wall infarction if that critical LAD lesion isn't treated urgently, usually with angiography and intervention. It's a warning sign of unstable critical coronary occlusion. You have to recognize it and act fast.
Got it. Finally, station 20, LVOT obstruction. This one seems geared towards hemodynamics. Q1 asks for the likely diagnosis based on findings, maybe from cath data or echo. Q2 asks for the name of the sign. This is likely where the Brockenbrough phenomenon comes in. And Q3 asks for the differentiating sign on cardiac catheterization from a dynamic obstruction.
Precisely. This station sets up the need to understand how to differentiate fixed versus dynamic left ventricular outflow tract, LVOT, obstruction using hemodynamic principles, particularly during cardiac catheterization.
Okay, this sounds like a complex but absolutely vital concept for advanced practice, especially in cardiology. How do you definitively distinguish aortic stenosis, AS, which is a fixed obstruction, from hypertrophic obstructive cardiomyopathy, HOCM, which causes a dynamic obstruction? You mentioned the key lies in how they respond to physiological maneuvers or changes.
That's exactly right. The response to changes in contractility or loading conditions is the giveaway. Let's start with fixed obstruction, aortic stenosis, AS.
Yeah.
Here, the problem is the valve itself, it's calcified, maybe congenitally fused. It simply doesn't open properly. The obstruction is relatively constant, fixed.
So maneuvers don't change the obstruction much?
Correct. Because of this fixed orifice, if you perform a maneuver that increases cardiac contractility, like measuring the beat immediately following a premature ventricular contraction, PVC, which has higher contractility, post-extrasystolic potentiation, the arterial pulse pressure generated by that stronger beat remains largely unchanged or might increase slightly compared to the baseline beat.
What about the physical exam signs?
On examination, AS gives you the classic signs of flow limitation across a fixed stenosis. The pulsus parvus et tardus, that weak parvus, and delayed parvus upstroke in the carotid or peripheral pulse. During cardiac catheterization, the pressure gradient measured across the aortic valve is relatively constant, and even with increased contractility, the peak left ventricular systolic pressure only increases moderately.
Okay, that's fixed obstruction. Now, what about dynamic obstruction, HOCM? How is that different?
HOCM is completely different physiologically. Here, the obstruction isn't caused by the valve itself, but by the physical interaction between the hypertrophied septum and the anterior leaflet of the mitral valve. During systole, the mitral valve leaflet gets pulled or pushed into the left ventricular outflow tract, LVOT. This is the systolic anterior motion we mentioned earlier.
And this obstruction is dynamic, meaning it changes.
Yes, it's exquisitely sensitive to changes in ventricular volume and contractility. Things that decrease LV volume, like standing up, Valsalva maneuver, or increased contractility make the LV cavity smaller and ejection faster, which actually worsens the SAM and increases the obstruction.
Ah, okay. So this is where that specific sign comes in the Brockenbrough-Braunwald-Morrow phenomenon.
Exactly. This is the classic hemodynamic finding during cardiac catheterization that proves dynamic LVOT obstruction. And it's what the examiners often want candidates to describe for station 20.
Explain it. What happens?
In HOCM, if you measure the pressures during a beat following a PVC hail, Remember, that post-PVC bead has significantly increased contractility. The obstruction gets dramatically worse
Worse? Why?
because that increased contractility does two things. It ejects blood even faster, and it makes the already small LV cavity even smaller at the end of systole. The faster blood flow creates a Venturi effect in the narrowed outflow tract, literally sucking the anterior mitral leaflet further into the LVOT. This dramatically increases the pressure gradient across the LVOT. So you see a massive, exaggerated spike in the left ventricular systolic pressure on that post-PVC bead. But, and this is the crucial part, because the obstruction is now so much worse, less blood actually manages to get out of the ventricle into the aorta.
So the peripheral pulse pressure.
Paradoxically drops. That's the Brockenbrough sign. A decrease in the aortic pulse pressure on the post-PVC bead, despite the huge increase in LV systolic pressure. It's the definitive proof of dynamic obstruction.
Wow. So in AS fixed, the post-PVC pulse pressure stays same, increases slightly. In HSCM dynamic, the post-PVC pulse pressure decreases.
Precisely. That's the key differentiator on cath. And the surface exam correlate is feeling the pulse weaken during a Valsalva maneuver, or when the patient stands up, maneuvers that decrease preload and worsen the dynamic obstruction.
That's a really clear explanation. Okay, let's look at the last few stations. Station 21, pharmacology and trials. Q1 asks for the mechanism of action and condition where a specific drug is used, maybe a newer agent.
Could be. For example, they might ask about an SGLT2 inhibitor, like dapagliflozin or empagliflozin. Mechanism: block glucose reabsorption in the kidney. Condition used, now foundational for heart failure, with or without diabetes, and also diabetes itself, chronic kidney disease.
Q2 then requires knowledge of the landmark trial associated with that drug for that indication, its primary endpoints, and major adverse effects.
Exactly. So for SGLT2 inhibitors and heart failure, you need to know trials like DAPA-HF or Emperor-Reduced. Primary endpoints were typically a composite of cardiovascular death or hospitalization for heart failure. Adverse effects include things like increased risk of genital mycotic infections, volume depletion, and the rare but serious euglycemic diabetic ketoacidosis. This confirms that knowing the evidence base, the key trials, is absolutely required.
Okay. Station 22, imaging abnormality. What is depicted and which modality is it? Perhaps an image showing an intracardiac mass may be seen on a transesophageal echo, TE.
Q2 asks, methods to tackle the abnormality. If it's a mass, options might include surgical excision or possibly medical management if it's thought to be a thrombus, and coagulation. Q3 asks for indications to treat. When would you intervene? Depends on the nature of the mass, tumor versus thrombus, its mobility, size, and whether it's causing symptoms or posing a high risk of embolization.
Makes sense. And the final clinical scenario, station 23, acute chest pain, shock ECG. Back to the critical patient. But this time it's a very young patient, 25-year-old male, acute excruciating chest pain, syncope. Pulse is rapid, 120 minutes. BP is critically low, 70 millimilli Hg systolic, severe shock, and ECG is shown.
Wow, severe shock and chest pain in a 25-year-old is highly alarming and less likely to be typical atherosclerotic MI. Key 1 diagnosis. Possibilities are broad but catastrophic. Could it be an acute coronary syndrome, ACSDMA, perhaps due to anomalous coronary artery or dissection? Could it be acute aortic dissection extending into coronaries or causing tamponade? Massive pulmonary embolism, myocarditis with cardiogenic shock, ruptured sinus of Valsalva aneurysm. The differential is wide and urgent.
So Q2 asks for investigation done and other useful investigations. Beyond the ECG and basic cardiac markers, what's essential here?
Given the catastrophic possibilities, you need investigations that can differentiate quickly. A bedside echocardiogram is crucial, looking for wall motion abnormalities, MI, pericardial effusion tamponade dissection, severe RV strain, PE, overall LV function, a chest X-ray, and very likely an urgent CT angiogram of the chest aortopulmonary arteries is needed to definitively rule out or rule in aortic dissection and PE. D-dimer might be useful if PE is suspected and CT isn't immediately available, but less helpful in such a sick patient.
Okay. And Q3 asks for risk scores used. Which ones apply here?
This tests the candidate's ability to apply structured risk assessment even in an emergency. Depending on the leading suspicion after initial assessment, they might mention the Gray score or TMI score if leaning towards ACS, perhaps the PC score, pulmonary embolism severity index if PE is high on the list, or maybe the ADDRS score, aortic dissection detection risk score, to guide urgency of imaging for dissection. It shows a systematic approach to triage.
Okay, time for our final MCQ, focusing on risk stratification in one of these scenarios.
Let's do it.
MCQ 10, risk stratification. Which clinical risk score is most commonly used internationally to predict short-term in-hospital and longer-term mortality risk, and to help guide management intensity in patients presenting with acute coronary syndrome, ACS, incorporating factors like age, heart rate, blood pressure, creatinine, and Killick class? A. CHADS-2 VASC score. B. GRACE score. C. CRB-65 score. D. Wells score.
The key score for risk stratification across the spectrum of ACS STEMI and NSTEMI is the B, GRACE score, Global Registry of Acute Coronary Events.
And why is GRACE so important?
Because it provides a validated quantitative estimate of mortality risk, both in-hospital and often up to 6 months. This risk estimate is essential for guiding management decisions. For example, deciding whether a patient needs urgent invasive strategy versus a more conservative approach, or determining the appropriate level of care, for example, CCU admission. It's a fundamental tool for managing ACS patients effectively based on their individual risk. CHADS-2 VASC is for stroke risk in AF, CRB-65 for pneumonia severity, and Wells for DVT-PE probability.
Okay, GRACE score for ACS. Got it. Let's conclude with our final application example, tying together how the structural knowledge of the exam translates directly into potentially life-saving clinical practice.
Good idea. Let's call it synthesizing clinical and structural knowledge.
Case example 3, synthesizing clinical and structural knowledge. Okay, picture a candidate facing that exact station tummy 3 scenario we just discussed. The 25-year-old with excruciating chest pain and profound shock. Under the immense pressure of the exam, their initial thought might jump to the most common cause of chest pain STEMI.
Natural first thought, maybe. But the age and severity should trigger caution.
Exactly. But because the exam structure, particularly the Viva section, has drilled into them the importance of generating broad differentials and listing appropriate investigations for each possibility, the candidate pauses. They recognize the severe hypotension and dramatic pain in such a young patient are highly atypical for a standard first MI.
They access that structured thinking pattern forced by the exam prep.
Right. The application is immediate and correct. They realize the highest immediate life-saving priority must be to rule out aortic dissection in this young person with catastrophic symptoms. They prioritize ordering the rapid CT angiogram, which was listed as a core investigation in Q2 for that station, specifically to exclude dissection or massive PE, putting structural diagnosis ahead of just assuming coronary thrombosis.
That quick, structured move, driven by the exam's emphasis on covering all life-threatening differentials, ensures the correct and timely investigation.
Absolutely. It's crucial for patient survival in real life, and critical for success in the exam context, too. The key lesson here is the meticulous, sometimes demanding structure of this DNB examination, forcing candidates to systematically list differentials, appropriate investigations, risk scores. It isn't just academic cruelty. It perfectly mirrors the essential safety nets and the disciplined methodology required by any competent specialist physician when facing a true medical emergency. The exam structure reinforces good clinical practice.
Well said. It trains the right habits of thought. Hashtag tag tag outro. We have spent quite a bit of time now meticulously decoding the blueprint of this really high-stakes practical exam. Let's try and quickly summarize maybe the 4 top takeaways that hopefully will stay with you, the listener, after this deep dive.
Okay, hit us with them.
1. Endurance and methodology are key. Remember, the DrNB practical exam is a 4-part, single-day marathon. It demands not just knowledge, but immediate synthesis, mental resilience, and stamina across the virtual OSCE, the clinical cases, the ward rounds, and the Vivas. Real competence is tested in the methodology of structured thinking, not just recalling facts.
Structure matters. Got it.
2. Master rapid triage, the OSCE rule. The virtual OSCE in particular necessitates ultra-rapid, highly accurate interpretation of complex medical images and data under severe time constraints. Remember that 4-minute rule per station, with no second chances to revise. You have to be fast and right.
4 minutes. Intense.
Understand hemodynamic principles. The assessment repeatedly hinges on differentiating things like fixed obstructions, aortic stenosis, from dynamic obstructions, HOCM. This requires a really deep understanding of complex physiological phenomena like that Brockenbrough-Braunwald-Marrow phenomena we discussed. It's not surface level.
Know your physiology under pressure.
4. Recognize the ultimate clinical imperative. Hemodynamic instability, specifically profound hypotension, like that BP of 80-50 millimiller Hg we kept seeing, is the absolute decision point in acute management. In any unstable tachyarrhythmia or structural emergency, instability overrides slower pharmacological approaches and dictates immediate electrical, surgical, or interventional action. Stability first.
Stability first. Great summary. We've really broken down the architecture of this intense assessment today, and the fact that the examiners demand this breadth and depth knowledge of landmark trials, historical figures, the ability to differentiate complex physiological phenomena on demand, it really tells us that being well informed isn't just optional, is it? It's the absolute indispensable foundation of expertise.
Couldn't agree more.
So the final provocative thought for you, the learner, is this. If you had 4 minutes right now, could you not just name, but could you physiologically explain the Venturi effect in the left ventricular outflow tract and how it contributes to dynamic obstruction in HOCM? Think about it. Keep exploring. Thank you for diving deep with us.